We're already there. Oh, I think. Good morning, ladies and gentlemen. You're welcome to another episode of Monitor Your Health by Dr. Femi Ogunremi. I hope your weekend has been going on fine. Today we have another interesting topic to discuss. It is known that there are challenges around our understanding of epilepsy. In this day and age, there are cases where we find children going into convulsion, and there are, beliefs and myths that people still tap into, and the way they treat some of those patients or people cause for concern. I've had situations where a child will go into convulsion and the parents will get hot wire or hot instruments to poke them. Sometimes they cut them, they lacerate them to make sure that, probably to stimulate them. And this is based on our belief. There are other situations where you find relative putting, things like salt, like concussion in a child's mouth, or even people who have fits or epilepsy or convulsion or things like that. So in order for us to understand this better, we have brought in a specialist who can actually tell us what are the facts that we need to know, what are the myths, what are the questions that people have asked that need urgent attention. And with me today is Dr. Adeboye, who is a consultant pediatrician and also with special interest in neurology. You're very much welcome, Dr. Adeboye.
Thank you very much, Dr. Graham.
Yes, please, can you introduce yourself to our viewers?
All right. So, thank you. Good morning, ladies and gentlemen, and good day to all over the world, because knowing that the time zone may be different, and this is probably being seen the world over. So I'm Dr. Adeboye Muhammed. I'm a pediatrician and associate professor of pediatrics with vast experience in pediatric neurology. Right. So childhood epilepsy is one of my core areas. Thank you very much. I hope that's enough.
Yeah, thank you so much. This gentleman has a lot of legs, so I know you just want to be modest about it. Thank you so much. Also, the chairman of can you help me with that? NDC.
MDCAN, Medical and Dental Consultant Association of Nigeria, UITH chapter.
Yeah. Thank you so much for giving us the time to be here today. So we talk about epilepsy. It's a topic that is very important. And, there are a lot of myths. I've recently had a patient, that we had serious issue because this child was given a concussion. What is epilepsy?
Thank you very much. I think we just need to differentiate certain terms here before we move on. And those terms are epilepsy, convulsion, and seizures, right? Let me just pick it by saying, what is a seizure? A seizure, from the English word, when a child seizes, right? Breaking it down further. So what happens that can make a child or even anybody seize, right? So it is as a result of abnormal neuronal discharge from the brain, right? So there are neurons in the brain, so that if some things go wrong there, so they can fire abnormally. And knowing fully that all the parts of the body are controlled by buttons within the brain. So now, depending on which area of the body is being represented by the area of the brain that is affected, right? So then we'll see the manifestation of the seizure. Now, for instance, if the area that are controlling a particular muscle, for instance, muscles of the upper limb and muscles of the lower limbs, right? So if the areas were the neurons that had some issues that had to discharge abnormally, so you see that part of the body moving, right? Often in a rhythmical fashion. Okay, so seizure is that abnormal neurological discharge from the brain, right? So now, depending on the area, so if it is motor area, now if it's area supplying muscles, you see movement of the muscles, and that is what is known as convulsions, right? Now, it can affect other senses, right? So somebody may just be hearing what is not. That can be a form of sensory seizure. Okay, so auditory, for instance, and in some climbing medicine, so that is regarded as a auditory hallucination. It can be a form of a seizure, right? But definitely not a convulsion, right? Now, again, if it affects what is known as a autonomic system in the body, right? So the person can just all of a sudden have a sudden sweat that can also dry up, or the heart rate can just become so fast and then later slows down. The respiratory pattern can be so fast and then slows down. All these are forms of seizures, right? So, but the one that affects the muscle movement, that you see the child shaking the hands or moving the legs or turning the head to one side and the head is also shaking. So those are the ones referred to as a convulsion. Now, what is epilepsy? The epilepsy is now a situation when a child now have seizures on recurrent basis. Now a child has one, either seizes once, maybe as a result of electrolyte imbalance in the body, maybe as a result of somewhat, okay, I believe some of the question will still go there. So maybe I should not preempt it too long. There are quite a number of things that can result in seizures. There are quite a number of things that can, make a child. So if this child now, de novo, to just have such episode, either in form of staring, just looking like that, which could be a form of seizure, or even convulsing, having the motor movements of the limbs, right? So if it becomes recurrent, we tag these as being epilepsy, right? I think in a nutshell, so that will not bring too much complication. This is simple differentiation. Okay, so to appreciate epilepsy, we need to know what convulsion is and what seizure is and what makes it epilepsy. Thank you.
Thank you so much. So now, you said quite a lot of things here. And when we talk about, hello?
I'm with you.
So sorry, I think we just had the power lot, the electricity is just gone, but I hope you guys can see me.
Oh, no, I'm with you. I'm okay.
All right, so now, when we talk about, you talk about auditory hallucination, which is the situation where somebody they will start, hearing things. So that can actually be a seizure.
Exactly. So that's the point. So even visual hallucination can be, so there are forms of sensory seizures.
Yeah.
So visual hallucination, he's the only one seeing what others are not seeing for some time. And then after some time, it clears off, right? He's no longer seeing it. It can be a visual hallucination. Same thing auditory, right? Thank you.
Thank you so much. So viewers at home, so I know that what we tend to believe as seizure or, being epilepsy is when we see people fall down and they start fitting and things like that. You can just hear it now. It can go beyond that. It can be a situation where individual, is seeing something, individual is hearing something, or they're feeling something, even working on their body and things like that. So there are a lot of aspects of this that can be a seizure. Thank you so much for that. So you've talked about the causes. Maybe we should go down that route. What are or maybe before we go into that, what are the things that people will see, to actually, I know we've talked about all these movements and you've just defined them. Are there things that, the viewers at home need to know? Because a lot of people, like I said earlier on, until they see somebody fall on the ground and then they start foaming, they start twitching. And then they say, oh yeah, that's that this person is suffered epilepsy. Are there other things aside the visual, the auditory, and things like that that people need to know about that to make them have the feeling that likelihood this person is suffering
Yeah.
from?
So
Yeah.
definitely, thank you so much, the host. There are quite a number of things that somebody can have that will point towards this person having a seizure. Firstly, it is important to know what happened during the delivery of that child, right? Because we are talking about childhood epilepsy. The emphasis is on childhood epilepsy, though some may be applicable even to older children or adults. So, but talking about, it won't be incomplete to talk about childhood epilepsy without talking about what happened during the delivery of that baby, right?
Right.
If the child had some difficult situation during the delivery process, or should we even start with the pregnancy? If the pregnancy was a problematic one, so probably the mother had a series of illness, had some obstetrics or complications, right? Like what the obstetrician will call a preeclampsia, right? Or when the child is about to be delivered, so eclampsia, preeclampsia. So when the blood pressure of that mother is so high that affects blood supply to the unborn baby, so that can lay a template for that child coming out with something that can be epilepsy later on in life, right? Also, by the time the child is delivered, if the delivery was a difficult one, okay, so probably the mother has been told, this your baby is big, let's please go for section, make it elective, and so on, and the mother felt otherwise, or the father refused to give approval, or something happened, and the baby was delivered through a very stormy delivery. Okay, so probably it was after the baby was arrested there that they now had to eventually settle for surgery. So meaning the child might have suffered a lot of injury to the brain. So during that process, that can lay a template. Of course, a child that was born normally, so and something happened, the child got infected with sepsis, with meningitis as a baby, right? That again can lay a template for epilepsy later on in life, right? Of course, some children are born, everything seems normal, but there is congenital anomaly within the brain. So that already lay templates. So now when these babies are delivered and as they grow, you probably observe that even some may convulse as newborn. Of course, the convulsion that the seizures that they may have seizures as newborn, the type of seizures that they may have quite different. Some of them may just be looking without blinking. So we call that staring gaze. So, right. So that is one. Of course, some may just be lip smacking, right? So they may just be licking their mouths. And the mother may complain that this baby will just be licking the lips, but you put breast milk in the mouth, the baby will not suckle, right? It's not because the baby just didn't want to suckle. Probably it was because the baby was having a seizure at that time, and the mother will not understand. So even some medical personnel may miss such seizure, and that is why the name is referred to as subtle seizure, right? The growth of some of those babies may be slow. They may have slow growth, so they may not develop well. So when it's time to crawl, the baby may have some delay. So these are some telltale signs that somebody can see. before epilepsy becomes established in the child. Of course, there are some of them that the child may just blink for a few seconds, right? And once that is done, in fact, I'm sure we'll still get to the various types. If the child wants to, if the child was eating, the spoon may just hang in the middle, right? And the seizure lasts few seconds, and then by the time it was over, the child will continue eating, right? So the spoon may not drop. Of course, there are quite a number that if it's about to happen, even a child may be able to tell mommy that thing is coming. Because they may have some feelings. So, and this is what will take us to what is called aura, A-U-R-A, right? They may have some feeling. Some, they may not be able to describe it fairly well. Some will just say they're feeling like something is crawling within them. And once they feel that, the next thing is for them to have a convulsion or a seizure, as the case may be, right? And some may just say, so their head is making some noise, right? Because some children can have what is known as automatic behavior, automatism, right? And what is this? There are different types of possible automatic behavior, right? So the child may just be rubbing his or her clothes or rubbing hands on certain part of the body, right? And a few minutes after that, the next thing is the child will convulse. So much so that either the child or the parents might have even associated the condition, so the behavior with impending seizure. And in most cases, they may not be wrong, right? In most cases, they may just be right. So these are some telltale signs, right? Again, so fearing that I should not answer some of your next question, so probably you should throw the next one. Thank you.
Okay. Thank you so much. That was quite explicit. So, I mean, it's not when we talk about seizure, when we talk about epilepsy, convulsion, and things like that, it's not only by jacking and foaming. So there are all it starts right from when the child is being born. Wow, that's great, and I hope that our viewers are learning from this. Now, so you were going to touch about the types. It sounds like there are different, the various types. There are different types.
Okay. Yeah.
So what are the types?
Right. It's okay. So thank you very much. Talking about the types, right? If we want to just divide it into broad categories, so there are some types that are general, that is the whole body is involved in the convulsion, right? And there are some types that are focal, that is certain parts of the body that are involved, right? And so some of those focal may just start as focal, and then eventually, so they go around the body. So such are the types that are referred to as focal with secondary generalization, right? And there are some types that are not fitting into this, right? So there are some that are unclassified, right? The generalized one can be what is referred to as tonic. So a tonic seizure is that type that when a child has, or when anybody, well, emphasis on the child now, so has, there is increased tension in the muscle groups of the body. We have said generalized now, so meaning virtually all the skeletal muscles, right? So will be stiff for a few seconds. So now, usually, when a child has a generalized tonic clonic seizure, so I'll break that down just in a while, right? So the tonic phase usually comes first. So during that tonic phase, that child will not breathe. The child will just be stiff. Of course, that phase is even more is the most frightening phase, for parents, for caregivers, for neighbors. And some of them will even say, don't allow him or her to clench teeth. Of course, the teeth are already clenched, so they want to force it to open. In the process, some of them will put their hands in the baby's mouth or in the child's mouth. And of course, if it's a child that has teeth already, so some of them suffer biting injury from such a baby. Of course, the baby or the child did not do it deliberately, right? Mm. So such a child can bite. Even some have bitten off fingers before because it was with a force that, that was extra for the child. Not under the control of the child, I mean, right? So that's the tonic phase. So, and after a few seconds, the clonic phase now sets in. That clonic phase is the one that is now said with a contraction and relaxation. See, the tonic was only contraction everywhere, every part of the body of that child becomes stiff. Mm-hmm. So the clonic is the one that is now said with the contraction and relaxation, and that can last for variable duration. In fact, depending on how they last again, so some interventions are necessary. So that is talking about tonic, then clonic, and also tonic-clonic under generalized seizure. Of course, there are some that are referred to as atonic. In such situation, the child will just lose the tone, the tension in the body. Once it happens, if the child was standing, the child will just fall down because all the tone in the body will just go, right? The child will just drop. So that is atonic seizure, right? So that's talking about tonic, clonic, then atonic, right? Because absence seizure, which was the type I mentioned briefly earlier on without attaching the name, in such, you just see the child having few blinks. The child will be staring and then will blink for some time, right? So in this one, if the child was having the seizures, if the child was having such seizure or such convulsion, and the child was eating when the seizure set in, when the convulsion occurred, right? So that's muscle, that spoon will just hang there. And then, so by the time it's off, maybe 3 seconds, maybe 4, 5 seconds, and then the child continues eating, right? So that's absence seizure, right? Of course, still under generalized form, we have what is known as infantile spasm, right? So that is seen often in young infants. Okay, so young infants, and it can continue as the child grow older, right, or change pattern. So this is like a spasm. The trunk and the muscles of the extremities of the child will just contract all of a sudden at once, and then the child will just go like they will have a spasm, right? And some of these can occur repeatedly, or some can just occur. So one after some time, another one occur. But these can follow each other over and over and over, right? Now, if we talk about focal seizures, right? Focal can just involve the hand, either the right hand or the left hand, or even the lower limb. So either the leg or either of the leg, right? So, and it can just occur. It can just stop after some time. So, and that's the focal only. Or it can continue and then involve the whole body. That's the focal with secondary generalization, right? Because now, irrespective of whichever it is, so if the consciousness of that child is preserved, it is referred to as a simple. Okay, so you can have simple focal seizure. So, but if consciousness is impaired, so meaning when the child does it, the child loses consciousness, either from the beginning or so while the focal seizure persists. So we say it's complex focal seizure, right? Of course, quite a number are there that are unclassified, so that can follow different patterns. But these are the common ones that I'm sure public can take note of. Thank you.
All right. Thank you so much, Doc. So that's very explicit. I mean, we now know that it's not only by ordinary, tonic-clonic conversion, which is exactly what you described earlier on, which seems to be the one that majority of the people tend to know. So it's not only when somebody is, jacking and they fall on the floor, or maybe they shouted or things like that, or they shout, that we're talking about them having either epilepsy or seizure or fit. So we now know what to look out for. Now, we know what to look out for, but what do we do when people have this? What are the things that we do? Like you said earlier on, somebody will put their hand in the mouth of the child, and the child will bite their hand off. Some people will say that, oh, this child, like Yoruba people will say, as in bring,
fire or hot rod. Yeah.
So what do they do?
Thank you so much. Thank you so much. I should just just say a few things about some harmful practices, so that in most cases adults do when a child or anybody convulses. Right, quite a number of harmful practices, especially in our setting, especially in developing nations. Some of those you have mentioned. Some will say, okay, if the child experiences pain, then the child will not convulse, as if the child was seizing deliberately, right? Of course, some will look for something hard and hit on some surfaces of the child, right? Like on the shin, they will, it may be so painful tapping the shin, right? So they will hit something hard on the shin. And some will say, okay, so plug that iron, so let's put it on the child. So we have seen children that had convulsion, so with mark of pressing iron on them, right? Of course, some can press the abdomen, so as if they want to force whatever in the stomach out, so that the child will just stop convulsion. Some will put onion in the child's eyes, right? Some will put pepper in the child's eyes. Of course, the majority will say, give us spoon, let's put spoon in the mouth. And some will put salt inside the baby's mouth, irrespective. And in fact, this will interest you, right? Some will say, okay, bring cow urine. So they call it agbo-letutu, right? So if you have agbo-letutu, so just pour it on the child's mouth. If you are not able to, so just rub it all over the body. And if the mother or whoever now says, we don't have agbo-letutu, and I say, where is the mother? Oh yeah, urinate in the child's mouth. Yes, can you imagine? So those are some harmful practices. Of course, there may still be one or two, but those are some common harmful practices that we want to tell the public to desist from doing this, right? They are harmful, okay, so to the child. And somebody can even aspirate, somebody who was having a seizure and unconscious, having convulsion as a result of epilepsy and unconscious, and then something was put into the mouth, okay? So, and it goes into the airway. So that child can die as a result of the intervention, not as a result of the convulsion. So, having mentioned what should not be done among those things that are being done by some of our people. So what do we advise if somebody all of a sudden a child just convulse and it happens to be outside, right? Of course, the first thing is to let the child just lie on we call the position left lateral position, right? So Of course, if there are tight wearings, okay, so necklace, tight clothing, we want to relieve all those, because without the knowledge of that child that was convulsing, so the child can choke him or herself, right? And we want to guide against this. Of course, we also want to take anything that can injure the child away from the vicinity of where the child was. So, for instance, if it happens in a place where there are many bottles, okay, so we want to clear the bottles away so that the child will not make a move, kick the bottle, kick one of the bottles, and then the whole crate just crash on many people, including the child. So we want to clear that, and then you know, ensure adequate aeration. That's not the time many people will just gather around the child that what is happening? I want to see. Okay, so you want to see the little oxygen that is available for the child to utilize. People exhaust it, and that further contribute to choking of the child. Right. Of course, so these are some, practices. Of course, if there is a close hospital to where that happened, right? Because once the child stops seizing, so the child can be taken. So usually most seizure will not last more than between 5 to 10 minutes. Some do occur. So I've mentioned some that can even last for seconds, right? Okay. So and once the child does that and the child is out of it, so we should just take them to the nearest hospital now for evaluation, and then if a referral is necessary, they will not refer such a child to be seen, and detailed history will be taken, and then appropriate medical management will be instituted. Right. Thank you very much.
Thank you so much for that. Now, is it every time? Okay, I know we've talked about the seizure, we've talked about convulsion. Is it every time that a child has seizure and convulsion that we say that they have epilepsy? Or is it every seizure and convulsion that will lead to epilepsy?
Now we need to.
Or can we clarify and fine tune the line?
Okay, so that we need to do what? I didn't get that aspect.
Okay, so is it every time that a child or we have a seizure? Every time they have seizures, is it every time that will lead to them having epilepsy, or how?
All right. So let me quickly. It means probably. So my earlier description of epilepsy is not clear yet. Right. So now, by the time seizures or convulsions. So now let me use convulsion in this case. By the time it becomes recurrent, okay, so that is epilepsy. Now, a child that is epileptic, right, needs to be evaluated in the hospital, and then so appropriate treatment will be commenced. So if a child has seizure or a child has convulsion now, so if we evaluate, if it was due to, the child was playing and the child hit his head against the wall, and then 10 minutes later, the child convulsed. So that is not epilepsy. So if the child has a fever, so the body was hot, so the child is like, let's say 2 years or up to 5 years, because febrile convulsion has a definition. If the child falls within that age definition of febrile convulsion, so usually 6 months to 5 years, right? If the child falls within that age range and then the child has a fever, right? Maybe from a tooth infection, so maybe from a body infection, maybe from malaria, right? So and the child convulses. So that is not epilepsy. That is just a febrile convulsion or a febrile seizure. So once we take care of that, we follow the child up, and that child is not epileptic. The child does not have epilepsy. So now, But if a child was born with a congenital anomaly within the brain, okay, so that will predispose the child to having recurrent convulsions or recurrent seizures, as the case may be. So such a child could be epileptic, right? So, but the child needed to be followed up in the hospital, and then due investigations will be done, and treatments will be given, right? So, just like so, a child may have some electrolyte imbalance. A child has diarrhea, for instance, and vomiting, then lost some electrolytes, and as a result of that, so has been to various places where they did not investigate, or a child had hypoglycemia, did not eat on time, or did not eat well, so then develop seizure or convulsion. Okay? Then you are able to evaluate the child, and then you observe the problem that the child has. So you take care of that problem of correcting the electrolytes or giving glucose, and then the convulsion or the seizure stops. That is not epilepsy. Okay, so in other words, it is not all convulsions that are epilepsy. Okay, I hope I clarified that.
Yes,
Thank
thank
you.
you so much for that clarification. Now, so will epilepsy or convulsion or seizure, will it run in the family?
Thank you so much. Right. Epilepsy runs in the family. It can. Okay. So, of course, if a child that was, for instance, delivered with a congenital anomaly in the brain, okay, so and the parents had no such disorder, right? Maybe they were not sure. Probably uh, some early ancestors had. Okay, so epilepsy can run in family. Febrile convulsions have even been identified that there are some categories of people uh, by the virtue of certain gene within them that if they have a fever, they will have convulsion later once the fever reaches a certain level. Or even some the fever may not be too high, but because they are predisposed to having that as a result of genetic predisposition, okay, so that is also possible, right? So, but is it a norm? So, can we say anybody who has epilepsy as an adult, all the children must have epilepsy? The answer is no, right? Uh, can we say everybody who had, or every parent who had a febrile convulsion as a child eventually give birth to children, that all of them must have no febrile seizures or febrile convulsion? The answer is still no, right? So it can run in family, not that it must run in family, not that it will run in family, right? Thank you very much.
Thank you so much. Now, having said all this, we understand that this can run in the family. We understand the symptoms and well, some of the signs that we can pick that will give us that this child has got something, maybe it's epilepsy, maybe not. How is it diagnosed? How do you then get to confirm, affirmatively that this child has actually, has some has epilepsy? What are the
Epilepsy. Thank,
indications?
thank you very much for that question. Right. So this is, part of the reason why if a child has, if the parents are worried about a child's condition, so it is better they present early. Now, we've mentioned some things that can, you know, predispose the child to having epilepsy, so congenital anomaly, especially of the brain. Okay, of course, the exposure to certain, toxins within the environment can also, right, predispose the child to. So, and of course, family history is also important. So, in investigating, making a diagnosis of epilepsy, the history and the physical examinations are very, very important. In the history, some of these things that we have mentioned, right from the situation at birth and so on and so forth, up to that present age, very important, right? Of course, as the child had some infections that could affect the brain, so meningitis, measles, and the likes. So they are very important to find out. Okay. Now, when we now examine this child, there are some telltale signs on the skin. Okay, so or on other parts of the body, so that can uh, advise you so to watch out, even if this child is not having seizure now, or the child does not have a seizure, so that it is not impossible that the child may develop a seizure disorder or epilepsy later on in life. So, for instance, there are some conditions that are referred to as neurocutaneous syndrome, right? Neuro is for neurons, cutaneous is skin, syndrome is association. So now, neurocutaneous syndromes conditions that of the nervous system, especially the central, can also be peripheral nervous system, and the skin. That when a child can have in a number of them can have epilepsy, right? And some I will just mention. So you see some children, so they complain, the parent complain, the child is actually not doing well, maybe developmentally, the child was delayed, and then later on they started to see that there are some few projections on the skin of the face, which we call tubers, right? Okay, this child could actually have a tuberous sclerosis. So tuberous sclerosis is a neurocutaneous syndrome. So that's can at the end of the day be associated with a childhood epilepsy. Of course, there are some children that as a result of incident they had as a baby, so the brain may not have opportunity of a good growth. Okay, so the head size will be so small, the brain will not be able to grow well, and that again, so they can. So size of the head is important. It must not be too small on average, and also must not be too large. So if it is too large, it can also be due to deposition within the brain of tissues that are not necessary. So these tissues are referred to as the glial tissue. And a child can have a head that is so big, but the content is, not significant. In fact, some children can have what is known as hydrocephalus. And for some of them, if there is early intervention, they might just escape. But even with intervention, some still come down with epilepsy later on in life. So now, these are just some, in making diagnosis, history is important. Physical examination is important. So you look at the skin, apart from other telltale signs of a condition like tuberous sclerosis, apart from the tubers on the face, there are some hypopigmentation, right, that can be seen on the skin, even hyperpigmentation. They can have what we call ash leaf macules. I'm not too sure. I need to go into detail of that. They can have caffeine spots as well, right? Of course, other neurocutaneous syndrome or other telltales that can be seen. So we can have a child with history of a convulsion and then you look at the skin, you see some outgrowth on the skin of the body, not just on the face this time around. And then they also have cafe spots. These may be what we call a neurofibromas, and that condition is a neurofibromatosis. There are different types of that. Again, I don't think we need to go into that. Of course, quite a number of other, lesions that history and physical examination can point for you. So now, after history, physical examination, the next thing in medical diagnosis is investigation, right? In investigating children with epilepsy, so a brain scan is very important. And here, when we talk about brain scan in children, we have a preference for MRI. MRI is a magnetic resonance imaging, rather than or unlike a CT. So not because of anything, but because of the possible radiation hazard that CT may come with. So, but MRI has no radiation. The only issue with MRI is the cost. And if we get a good machine for the MRI, it can tell us many things about the brain. So if there are areas of abnormalities within the brain, if there are areas of infarction within the brain, all those can be seen, and these can be pointed. Of course, in some of them, all these may be done, and then there is no abnormality that we are able to detect. But clinically, so once we are convinced, so in that this child has a convulsion or a seizure repeatedly, okay, without any obvious provocation, we still go ahead and manage that child clinically as a case of epilepsy, right? And some of them, the type of the convulsion is so peculiar, right? Like once you see it, so you know that, okay, this is this syndrome. It is associated with this condition. There are some of them that a child that was normal, for instance, up to a certain age, then develops seizure and start to lose his speech and hearing ability. There is a condition that is associated with that form of epilepsy in a child. Of course, we take care of the child like that. So, in summary, in diagnosis, history is important, physical examination is important, and investigation is important. Thank you very much.
Thank you so much. We're getting to the end of the program now, and I just want to reiterate the facts to our viewers that obviously from what Dr. Adeboye just told us now, we realize that it's important for us to be very vigilant, because from the diagnosis now, he has talked about the history, the examination, and investigation. I mean, the examination is not only the doctors. That's the essence of things like this. So that there are things that you see on your child, whether on the body, they're not normal. The earlier you prompt your doctor to have a look, the better. I've seen cases where mothers would come to me and tell me that this is not normal for my child, or they found something just abnormal. To me, I might even see this as being normal. But when a mother or a relative, when they reiterate the fact that this is not normal, I always take time to listen. And that's where I want to also cross it with my colleagues. If a mother or a relative come with their patient and they tell you that something is abnormal, this is not right for them, please let us take time to have a look so that we don't miss important things, just like we've just been told now. So thank you so much, Doc. We've talked about epilepsy, and I think we've concentrated a lot on on children. Yeah. Is it the same as in adults as well? Or are you in the position to tell us that, because people will be wondering, okay, they talk about epilepsy, they talk about kids, children all the time. Is it the same way or similar in adult? We only have about maybe 5 minutes left.
It's okay. So there's some similarity and some differences in between childhood and adult epilepsy. But I think, so that you may need to, bring in another expert. There is a topic on it, or treat it another time. Of course, I'm a child specialist. I'll be biased for children any day, anytime. But I'll just mention this. Febrile convulsion, for instance, is 100% a childhood thing. So we don't talk about adult having febrile convulsion. Of course, maybe we should just leave that. There are quite a number of differences. Of course, there may be some similarity between childhood and adult epilepsy, right? So thank you so much. I'm not too sure. You will still ask me about if it is treatable, if there are some challenges in the treatment. But can I quickly take?
Yes, please. I was going to ask you. Yeah.
Thank you so much. Is it treatable? Yes, quite a number of them are actually treatable. But it would be so nice if the presentation were early. Not that they told us that they don't take care of this one in the hospital, and they're coming with a child, 14-year-old, who has been having convulsions since shortly after delivery. They said doctors cannot do anything about this one, and that's why we are just coming now at the age of 14 years. Of course, then they will now expect you to just do something, and then for the seizure to just disappear, or for the epilepsy to just disappear. No, it won't happen like that. It is important they present early. Quite a number of them do respond to treatment. And the treatment is such that even when the correct diagnosis is made and treatment is commenced, you start to see the improvements, and then you are tempted as a parent to say, they just say we should be using medication for this child. 2 months has gone now. This child is not having any problem again. So please don't stop such medication until you are told to do so. Even medically, we won't stop it until about 2 years, and we'll start tailing it down, not even stopping at that point in time. So we'll start, we'll tail it down gradually. But one, we need to be sure the child has epilepsy or a seizure disorder. The child needs the medication that we want to give, right? And then we are both committed on the parts of the caregiver as well as the parents in managing the child. Not that go and take your drug. If you like, use it. If you don't like, use it. Don't use it. No, because compliance is very, very important, and timing is also very important. All these will be stressed out when they present. So early presentation do good to both the doctor as well as the parents as well as the children themselves. Early present. So the challenges, technically, I've mentioned some of them. Okay, so what parents do? So some of the challenges are like they will not come early. They don't present early, and you prescribe medication they don't buy, or even they want to buy, they cannot find, right? And they just think this child is giving them too much trouble. Okay, so going after what should not be, not starting early, and like that. So those are some of the challenges we do have. Of course, at times the medication that we know is effective may not be available, right? And it's like this COVID period, for instance. Quite a number of them, so that I would not be advertising certain medications, right? Some of them are not available, and it seems to be a nationwide thing, right? Okay, I think that's just briefly on that. Thank you very much.
Thank you so much. I think we on that note, we're going to just we're going to close this session. But before we go, I just want, do you have any advice for the parents? Maybe for like 30 seconds.
Okay, so thank you so much. Parents, so if you have a child with convulsions or with epilepsy, right, so please don't be ashamed. It's a global thing. It's not because of some witches or some wizard or some that don't want progress for you. It happens everywhere in the world, all right? And they respond to treatment everywhere in the world. Present early, Okay, save the child. Who knows? This child can be something very significant for you in future. Thank you.
Thank you so much. And just to add on to that as well, just like it's being a child of the world when they have this, remember, don't pour things in their mouth. It's not the right time. You do that, they can aspirate because it's
Yeah.
problem. We talk about concussion. You give this concussion that it can even affect the child's brain, you know. So the best thing you can do at that time is clear the environment, make it safe for the child. Put them on the left lateral position, which is like you lie them on the left-hand side so that the mouth falls on one side that way. And if they vomit out, you can easily help them. Don't put things in their mouth. Don't throw it, And obviously, don't burn their legs. It's a terrible thing to happen when people burn other people's leg because they had, a seizure. So thank you so much. I hope this has been an exciting and useful session for you, or educative session. And we look forward to seeing you again next week when we come up with another topic. We're very grateful for you always being there for us. Dr. Adeboye, it's been a pleasure, hooking up again with you, and really want to thank you for your time. Despite, how busy you are, we really appreciate you. So to the
Thank you very
viewers,
much.
have a nice weekend and see you next.